We will talk about the treatment of asthma and status asthmaticus. So asthma is a reversible condition which will respond very well to steroids. So first we will give salbutamol and levosalbutamol, aka albuterol or levoalbuterol. It's the same thing. We will give 2.5 to 5 mg every 20 minutes for 3 doses. यानी बैक टू बैक नैप 3 times for 1 hour जो हम देते थे. लेवोसाल्बुटामोल का डोज इसका हाफ होता है 1.25 to 2.5 mg. Only selective beta 2 agonists are recommended. A selective beta 2 agonist which is given IV is your terbutaline. It is 1 mg per ml given 2 microgram per kg bolus, then 5 microgram per kg per hour infusion. So याद रखना terbutaline selective beta 2 agonist IV 2 microgram per kg bolus, then 5 microgram per kg per hour infusion. Systemic agent में we can give epinephrine, IV epinephrine, मतलब epinephrine we can give in asthma 0.3 to 0.5 mg every 20 minutes for 3 doses subcutaneous और IM. सो एनाफिलेक्सिस की ही सेम डोज है बेसिकली स्टेटस अस्थमैटिकस में भी 0.3 to 0.5 mg सबक्यूटेनियस और IM every 20 minutes for maximum 3 doses. If you want to give ipratropium, it is given 500 microgram or 0.5 milligram every 20 minutes for 3 doses and then SOS. MDI can be given, each puff is 18 microgram. इप्राट्रोपियम का 1 puff is 18 माइक्रोग्राम, तो MDI से भी दे सकते हैं. यू कैन गिव अ कॉम्बिनेशन सोल्यूशन ऑफ साल्बुटामोल प्लस इप्राट्रोपियम which is 500 microgram of ipratropium 0.5 mg plus 2.5 mg of salbutamol. And you can give systemic steroids prednisolone 42 mg 80 mg or methyl prednisolone 1 mg per kg QID. You can give methyl prednisolone 1 mg per kg QID. Tintinali says that meter dose inhaler is better than a nebulizer because MDI delivers most of the dose to the target airways, but the nebulizer just wastes a lot of drug is in the air. So MDI is always better than nebulizer. If the patient is already taking some MDI with him, use the MDI. We can also use long-acting beta-2 agonists like salmeterol, zinafoate and formoterol. We can use IV methylprednisolone 1 mg per kg and prednisolone 40 to 60 mg per day. If we are giving prednisolone for less than equal 10 days, we do not have to taper it. We can stop it abruptly. We can also give a 2-day course of oral dexamethasone. Why only 2 days? Because dexamethasone has a very longer duration of action. A single dose depomethylpred 150 mg IM is another option. We can also give inhaled corticosteroids. Adding multiple doses of ipratropium bromide to a short-acting selective beta agonist, beta 2 agonist, may improve bronchodilation and decrease the rate of hospitalization among patients with moderate to severe asthma. In patients with poor response to therapy, means despite the therapy, if their PEFR, which is peak expiratory flow rate, is less than 40% of predicted, these patients need to be admitted and hospitalized. Now coming to status asthmaticus. Acute severe asthma. It is an acute severe asthma that does not improve with usual doses of inhaled bronchodilators and corticosteroids. There are findings such as hypoxemia, tachypnea, tachycardia, accessory muscle use, wheezing, audible wheezing. Rapid and aggressive bronchodilator treatment is the key of preventing a cardiopulmonary arrest. So it is an acute severe asthma that is causing respiratory failure. Rapid and aggressive bronchodilator treatment is the key to preventing cardiopulmonary arrest. Other adjuncts can also be used like magnesium, NIV, HFNC, ketamine and ADR. So IV magnesium can aid the management of acute very severe asthma. The dose is 2 gram in 100 ml NS, IV over 30 minutes. Nebulized magnesium is also effective and may improve pulmonary function. If you are using magnesium is anti of calcium, so you need to monitor the vitals, urine output and deep tendon refluxes and heart rate and blood pressure of the patient. Because hypotension and neuromuscular blockade may occur via magnesium. Other drugs are your ketamine and epinephrine. Ketamine inhibits uptake of NORAD and increases circulating catecholamines. And we know that catecholamines are bronchodilator. IV ketamine 0.15 mg per kg, then 0.25 mg per kg per hour infusion is used. If intubation is needed, ketamine is used as a pre-medication and sedative agent. Next is NIV. Start NIV early and do not start it when the patient is having altered sensorium or near respiratory collapse. Exclude pneumothorax before starting non-invasive ventilation. Next is epinephrine. It is a standard treatment for anaphylactic asthma. Epinephrine subcutaneous or IM 0.5 mg is given, similar to the EpiPen. Next is mechanical ventilation. Mechanical ventilation does not relieve the airflow obstruction, mind it. You have put the tube in the trachea, it's not going to ventilate the lungs. It's the drugs that open up the small airway will ventilate. The tube merely reduces the work of breathing and enables the patient to rest while the airway obstruction is resolved by your drugs. You can give a permissive hypercapnia or a permissive hypoventilation or permissive hypercapnia in a COPD patient. There are agents of uncertain or no benefit in the status asthmaticus like Heliox, methylxanthine, cromolyn, nedocromil and leukotrienes. They are not beneficial. How do you discharge an asthma patient in ED? Give them MDI with a spacer, valved holding chamber called spacer. You can also advise them nebulizer. You give them short-acting beta-2 agonist, 2 to 6 puff every 4 hours. Corticosteroids, oral medications like methylpred. You give them a peak expiratory flow meter and ask them to keep a PEFR diary, measure morning and night, and record best of the 3 ties each time. So in the morning you will blow air 3 times and you will write the maximum reading of those 3, not adding the 3. Follow-up visit is within 1 to 4 weeks. Next is COPD. How will we classify COPD? We classify it into mild, moderate, severe and very severe. Mild is FEV1 more than 80. Moderate is 80 to 50%. Severe is 50 to 30%, less than 30%. So mild, moderate, severe, very severe, 80, 50, 30 and less than 30% of FEV1 predicted. FEV1 less than 30% of predicted. What are the indications of LTOT or long-term oxygen in COPD patient? The treatment for COPD includes oxygen, drugs, decreasing mucus secretion, smoking cessation, and pulmonary rehabilitation. Long-term oxygen therapy reduces COPD mortality. The goal is to increase the baseline PaO2 to more than 60 or SaO2 to 88 to 92% at rest. We will provide LTOT in patients with less than 55 PO2 at rest or less than 88 SpO2 or at rest to all patients, or in second condition, if the patient is having pulmonary artery hypertension, cor pulmonale or polycythemia, any patient with less than 60 PO2 will be provided LTOT. So less than 55 all patients, 55 to 60 with patients with pulmonary artery hypertension, cor pulmonale and polycythemia. These are the recent GOLD 2026 guidelines. What is COPD? It is a heterogeneous lung condition characterized by chronic respiratory symptoms, dyspnea, cough, sputum production and exacerbation due to abnormalities of the airway, bronchitis and bronchiolitis, and or alveoli emphysema that can persistent airflow obstruction. So chronic persistent airflow obstruction due to abnormalities of the airway or the alveoli. Cigarette smoking is the biggest risk factor. Minimum cigarette exposure is 10 pack years is required. This is the spirometric algorithm. Measure of pre-diameter FEV1 by FVC. If it is more than 0.7, it's not COPD. If it is less than 0.7, you are going to give a bronchodilator and then measure again. If it is more than 0.7, it is not COPD, likely asthma. If it's still less than 0.7, FEV1 by FVC post bronchodilator is less than 0.7, it is COPD confirmed. These are the GOLD classification. GOLD 1 is mild, 2 is moderate, 3 is severe, 4 is very severe. So more than 80%, FEV1 more than 80% of predicted, 80 to 50, 30 to 50 and less than 30. Then MMRC classification. MMRC grade 0 is getting breathless with very heavy exercise. MMRC 1 is walking a slight hill पे shortness of breath होना. Grade 2 is मतलब लेवल पे ही नॉर्मल लेवल पे चलने पे ही SOV. Grade 3 is 100 meter. Walking about 100 meter is grade 3. 100 is 3 and 4 is breathless is at rest or breathless with very minimal task. So if the spirometry confirms COPD, we will assess the airflow obstruction and assess the symptoms. If the patient has MMRC 0 or 1 and CAT score, CAAT score less than 10, it is class A. If MMRC more than equal to or CAT more than 10, it is class B. Then 0 if the patient does not have any exacerbation. 0 moderate or severe exacerbation in the past year. Past year में कोई उसका exacerbation नहीं था, तो it will be A or B. And if the patient had even one exacerbation in previous year, it will be straight away E. So if the patient had 0 moderate or severe exacerbation in the previous year, it will be A or B. A if the MMRC is also low and B if MMRC is 2 or more. E will be if the patient had even one moderate or severe exacerbation in the past year. What is the treatment? For A you will use SABA or SAMA. For B you will use LABA or LAMA, and E you will use LAMA plus LABA plus ICS, inhaled corticosteroids. Coming to emphysema, smokers have centrilobular emphysema. Alpha-1 antitrypsin deficiency has panlobular emphysema. And smoker also have paraseptal emphysema. It is very important to humidify the airway of a COPD patient and to not irritate it. Always provide a humidified oxygen and proper hydration because of the integrity of the respiratory epithelium as well as mobilization of the secretion so that the infections can clear. Provide pneumococcal and influenza vaccine. How will you manage COPD in emergency? Exacerbation of COPD in emergency. So assess the severity of the patient, administer oxygen, cardiovascular monitoring, ABG, bronchodilators, beta 2 agonist and anticholinergics, steroids, antibiotics, non-invasive ventilation, and chest X-ray CBC. Assess the associated comorbidities and treat the cor pulmonale. What are the differentiating features in COPD and asthma? So asthma is a young onset, family history and reversible airflow is there. COPD has prolonged history with structural lung destruction. The most common agents directed at the COPD exacerbations are your Streptococcus pneumoniae, aka pneumococcus, Haemophilus influenza, and Moraxella catarrhalis. You need to target antibiotics in COPD against your pneumococcus, Haemophilus, and Moraxella catarrhalis. Use assisted mechanical ventilation when there is evidence of respiratory muscle fatigue, worsening respiratory acidosis, reducing mental status, and refractory hypoxemia. Whenever you see a patient with fatigue, increase CO2 or acidosis, reducing GCS, and refractory hypoxemia, start NIV. If it fails, intubate. What are the indications and relative contraindications of NIV? First is the selection criteria. So any acidosis, pH less than 7.36, any hypercapnia, CO2 more than 50, any PO2 less than 60 or saturation less than 90 is a criteria for NIV. Plus, the patient should be able to take his own breath. Severe dyspnea with clinical signs such as clear-cut respiratory muscle fatigue and increased work of breathing are the selection criteria for NIV. Exclusion criteria, respiratory arrest. And sometimes it becomes very difficult to know what is arrest and what is just fatigue. So you need to be completely vigilant while you are applying NIV. Be prepared for an intubation. Exclusion criteria, respiratory arrest means there is bilateral absent air entry. The patient is not able to take his own breath. So being able to take his own breath is the ultimate requirement for an NIV. There is cardiovascular instability like hypotension, arrhythmia, myocardial infarction. In these cases, you need to be very vigilant while applying positive pressure ventilation. And it may be possible that the hypoxia is worsening and the patient is undergoing hypoxemic arrest, causing hypotension, arrhythmia, and MI. The patient's GCS is starting falling and he is uncooperative or intolerant of NIV. If there is high aspiration risk, if the patient has viscous or copious secretions, recent facial or gastroesophageal surgery, craniofacial trauma. Why will we not use NIV? Because GI surgery, the NIV is going to insufflate your stomach and it might lead to GI perforation and facial disfiguration. There is craniofacial trauma And if you apply NIV in this patient, it can lead to pneumocephalus. Fixed nasopharyngeal abnormalities are there. If burns are there and extreme obesity is there, these are the exclusion criteria for NIV. What are the indications? What are the indications for intubation with mechanical ventilation? If the patient is unable to tolerate NIV, there is respiratory or cardiac arrest, respiratory failure, reduced GCS, increased agitation, massive aspiration, inability to remove respiratory secretion, hypotension, persistent hypoxemia despite A or NIV, and hemodynamic instability. So unstable vitals and GCS and increased secretion, aspiration or uncooperative patient are your indications for intubation.